point I will take us off the recording. I encourage you to get a paper and piece of paper or a pad of paper and a pen and jot down questions as we go. I will not be stopping, after each lesson and asking for questions because there's too much content to be able to zip through if we do that. It's also possible that I'll answer your question. So here we go. This is the Medicare prescription drug coverage module adapted for the Washington SHIBA. Almost all of you know what the SHIBA program is. It's the statewide health insurance benefits advisors. We're funded by the Administration on Community Living. Formerly, we were funded directly by CMS. We're utilizing today CMS material, which is very accurate and very detailed and supported by CMS. It uses CMS vocabulary, which is important because as advisors, we want to use accurate vocabulary so that when consumers call 1-800-Medicare, they are best able to advocate for themselves using the language that Medicare understands. This presentation covers not just Medicare Part D, like drugs, but Part A, like apple, as well as Part B, like boy, and Part C, like cat. The SHIBA program is part of the Office of the Insurance Commissioner. We're in the Consumer Protection Division. We have 400 or so volunteers. That number's always growing, and we're always losing a few, but generally 400. We provide authoritative and current information. We do one-on-one counseling around the state through 20 or so sponsors, and we do outreach to educate Medicare beneficiaries, their families, and their caregivers. We are unbiased and objective. We provide facts. We do not sell any products. We're beginning Module 9. This is the National Training Programs product from CMS. It's one of 15 modules. When I started learning Medicare, I learned from the 13 modules, and I always go back to these reference documents as my authoritative reference sources. The lessons, there are 7 lessons in this curriculum, and you can see on slide number 6 the names of the lessons. The learning objectives in general is that you will, by the end of this webinar, be able to differentiate the various parts of Medicare and how they treat drug coverage. You'll be able to summarize Part D, as in drugs, eligibility and enrollment requirements. You'll be able to assist people in how to compare and choose drug plans. You'll be knowledgeable and be able to describe extra help with prescription drug plan costs, and you'll be able to explain coverage determinations and the appeals process. It is not expected by anybody that any of you memorize this material. That is why you have a module that you can print out. And I would recommend, if you want to print it out, that you print out the notes page, which gives you descriptive information that you can use as a script as you're helping clients, whether you're in a pharmacy or whether you're in a SHIBA program. You will not go wrong printing this out or saving it on your desktop as a document to refer to. We all know that there are 4 basic parts of Medicare: Part A, B, C, which we also call Medicare Advantage plans. We call them HMOs. We call them PPOs. We call them Medicare health plans. And we call them by some other names. There are some PACE programs. And then Part D as in drugs. Prescription drug coverage under Medicare is dependent upon a variety of factors. the medical necessity for a person to have a specific drug, the setting in which they get it, why they need it, in other words, what medical condition the drug is being used for, and any special drug coverage requirements. For example, 6% of people on Medicare are on Medicare due to end-stage renal disease. They're either having waiting to get a kidney transplant, have had a transplant, or they're on dialysis, probably for the rest of their lives. Transplant patients have to have immunosuppressive drugs so that their body will not reject the new organ. So there's very specific requirements for them and for other people depending upon the condition that they're being treated for. Generally speaking, Medicare Part A, as in Apple, pays for all the drugs that are covered for a person when they are in the hospital. Now this gets a bit nuanced. The drugs that they get through Part A are to treat the symptoms and the reason for which they are being hospitalized. If a person is in the hospital as a Part A admitted patient, an inpatient in the hospital with a room, with a bed, with the green jello at night, with the constant intercoms going on, and all the other lovely things, excuse me, they will receive the medications that they need related to the reason for their hospitalization. We'll get into that a little bit more. Likewise, Medicare Part A, as in Apple, covers all of the prescriptions that a person needs if they have been certified for hospice care, whether they're at home experiencing the end of their life and are certified for hospice care at home, or whether they're in a hospice facility. All the medications that they get until they pass away are going to be covered under Part A. Part D will no longer be operative for them once they've certified under hospice care. There's a whole separate module that I would be happy to give a webinar on sometime about hospice coverage. Part B, as in Bravo, and you're welcome to look along with me. The slide number the slide number 12 relates to the notes, page 12, that some of you have in front of you. So Medicare Part B, as in Bravo, is used under certain circumstances to pay for medications. Some examples are immunizations that are given by a provider, such as the flu shot, such as a tetanus shot if you go into the office having been, after stepping on a rusty nail, if the nurse practitioner or healthcare provider gives you a shot in the office, that's administered under a Part B stay, or under a Part B setting, that's going to be billed to Medicare Part B, as in boy. Some other examples are if you have a device, a durable medical device such as an infusion pump and you need baclofen, the baclofen that you purchase to put into that pump is going to be billed to Medicare Part B, as in boy. Also nebulizers. So the material that you insert into the nebulizer, since the nebulizer is a Part B device, so will the steroid material that you breathe through that nebulizer. So hepatitis B shots, the pneumococcal shots, flu shots are also given under Part B, as in boy. I guess I'm not being consistent. I'm saying B as in boy and B as in Bravo. I'll stick with Bravo. If a person is in the emergency room, which is outpatient, which is Part B as in Bravo, and for, let's say, a broken ankle, they may be administered a pain medication because they're in severe pain due to the broken ankle, but if they need their blood pressure medication while they're in the emergency room and the hospital gives them a pill, that is not going to be covered under Part B because that's considered a self-administrable drug that Part D normally would pay for, and in fact, Part D might have already paid for that individual. So if a person is in a Part B setting and takes a medication that's really a Part D drug, they may have to pay the hospital or the setting and then submit to their Part D plan for reimbursement. I'm going to skip the knowledge questions. I think I'll skip them in the interest of time. Lesson 2 is about Medicare Part D benefits and costs. This is page or slide number 17. All Medicare Part D drug plans are approved by Medicare. They're run by private companies, approved by the federal government, and available to everyone with Medicare. In most cases, people have to proactively join a plan to have Part D coverage. But as we know, not in all cases, because some people get automatically enrolled or they have a facilitated enrollment, and we'll cover that in the lesson about extra help. But the two basic ways that people get Medicare Part D coverage is through a standalone plan or through a Medicare Advantage plan that includes prescription drug coverage. All the plans are flexible in their benefit design. They have to offer, oh, I just remembered I have a pointer which I could use. All plans have to offer at least a standard level of coverage which we tend to call basic. All the plans are going to be different in terms of how much they cost, what drugs are covered, and how they tier or categorize the medications in their formulary or in their list. All the plans are slightly different in terms of how they slice and dice the monthly premiums and what the co-payments are going to be, or whether there's going to be a co-insurance. And some plans select to provide enhanced coverage and cover medications that are not typically covered under Part D. And all plans legally can change their benefits and their costs each year. And we know that they do. The costs vary by plan. In 2018, most people, but not all people, will have a monthly premium, an annual deductible, co-payments or co-insurance, and if they hit the coverage gap, they will pay 35% of the cost of the brand name drugs while they're in the coverage gap, and 44% of the cost of generic drugs while they're in the coverage gap. After they come out of that gap, or that donut hole, as we call it, they will have very little spending after they have spent $5,000, which is a huge amount. In Washington, we have a list, you may already have it, showing that the lowest cost plan in 2018 for a standalone Part D plan will be the Envision RX Plus for $12.60 a month, a $300 annual deductible, and the highest cost plan is will come in at, and that's the Assurus or Assurus, I think you say Assurus, I'm not sure, Medicare Script Enhanced Plan. Note the word enhanced. It's $160.50, so that looks like the highest cost plan, and that's an enhanced plan, not a basic plan. it may have a variety of enhancements, such as coverage during the donut hole. It likely, for $160 a month, is going to be more flexible in covering some of the very expensive brand name drugs. I haven't looked at the details of the plan, but that's quite a range from $1,260 to the least expensive to $160. I haven't done a study, and I don't know if I will, to tell you what the average cost is. But you know, many people are going to pick a plan or stay in their existing plan that's $20 or $30. That is not a scientific analysis, but that's my guess. On slide number 21, you see a chart, left to right chart. There's 100 different ways to describe how Medicare prescription drug periods work. You know, you've seen graphs of the donut hole. You've seen all kinds of examples of trying to explain this extremely technical and complicated stuff. But one way to look at it is that there are 4 periods in a year. There are 4 Medicare Part D periods. There's the deductible period. And by the way, I did my very best to update this PowerPoint with the 2018 numbers. So if you see a discrepancy, do email me and let me know so that I can change it. My email address is on the last slide. So there's the deductible period, during which time the person pays as much as the deductible of $405 in 2018 until they've satisfied that deductible. Then they move into the next period, which we call the co-payment or co-insurance period. And that's when Mrs. Smith, in this example, pays the copay. Her plan, her Part D plan, pays its share until together they've reached the $3,750 maximum cost. At that point, the person is then in the coverage gap, or the donut hole period, because between the client and the plan, they've paid $3,750. After that, she's going to, or the client is going to pay those lower amounts, the 35% and the 44% of their brand name drugs and their generic drugs, respectively. Once the person has paid out $5,000 out of pocket, that person then goes into the catastrophic coverage period. At that point, the person's going to pay either 5% of the cost of their medications, or I believe it's, and I think there's a slide, $3.50 for generics, or $8.50 for brand name drugs, whichever is more. I will clarify that in another slide. But it's relatively a low cost if you've survived the donut hole, been able to pay for your medications, and there's any time left in that year. So the donut hole's closing. That's a good thing. In 2 more years, we'll be able to say there is no donut hole. People will pay 25% of the cost of their meds, and that's in parity with other prescription insurance. Now, there's a lot of details around what is it exactly that accrues towards that $5,000, which we call the true out-of-pocket costs, also known as TROOP. And there's several slides here, and I decided last night when I was reviewing this to not go over all the details of what counts towards the TROOP and what doesn't count towards the TROOP. There's a slide that describes that. It's pretty detailed. So there's a slide on what counts, what doesn't count, and what counts. This whole process is so behind the scenes for the beneficiary, and in my experience, people don't ask very much about this. It's great for you to study it and understand it, but as I mentioned, I'm not going exhaustively through slide by slide. I'm more touching upon and illustrating the major points. So I'm going to let you study that on your own. If you want to contact me later about it, I'd love to talk about it. But it's pretty deep down into the Medicare hole, and I'd rather not go there now. What I do want to mention, though, is in addition to the typical monthly premium, we probably all are pretty familiar with the fact that there's an IRMA, an income-related monthly adjustment amount, that some people, about 5% of Americans, will experience. And that means that they're going to pay, in addition to the monthly premium, they're going to be paying another fee directly to the federal government in order to keep their Part D costs, coverage. The same people that are subject to the Medicare Part B IRMA are also subject to the Part D IRMA because the thresholds, the brackets are the same in terms of income for people filing singly with their IRS tax returns and people filing jointly. If a person pays their monthly Part D premium but fails to pay their IRMA, they will be disenrolled. So it is not an optional thing. These are the brackets. I believe that I did not have the 2018 numbers. So this is the these are the 2017 additional costs added to the monthly premium. Oh, let me just say that while paying the IRMA is not optional, appealing it or asking for a redetermination from Social Security is possible. So if a person disagrees with the IRMA or they've had a life-changing event, they may be able to get rid of the IRMA, but they should pay it until that appeal has been settled. Otherwise, they risk being disenrolled. And then that is a nightmare if they're going to try to get a special enrollment period because they were in an appeal process, because that is does not kick a person into a special enrollment period. Okay, we're moving on to Lesson 3, slide number 30. And this covers information about what's covered, what's not covered, the 3 horrible hoops, which I'll get into, and I'm going to probably gloss over MTM, medication therapy management. So Medicare drug plans have to cover generics and brand-named drugs, but not all plans have to cover all of them. To be covered under a Medicare Part D plan, a drug must be available by prescription. It must be approved by the FDA, used and sold in the United States, not necessarily manufactured in the United States, but used and sold in the United States for a medically accepted indication. Medicare covers insulin, prescription drugs, biological products, such as antibodies, proteins, cells, etc. Medicare also covers the supplies associated with the injection of those items, but those are covered under Part B, such as alcohol swabs, gauze, needles, lancets, syringes, and tons of other durable medical supplies. Every plan has a formulary. The formulary is simply a list of all the medications that for that year are covered, are considered on formulary for the plan. There are various categories, and every Medicare drug plan has to cover at least 2 drugs in each category. But each plan can decide which 2 specific drugs they're going to cover under that category. And the coverage and the rules vary by plan, and that's what impacts people's cost. So even if a plan's formulary doesn't include a person's very specific drug, in most cases a similar drug is going to be available. So let's say that a person's supposed to take pravastatin, and that formulary doesn't cover pravastatin, but it covers simvastatin and atorvastatin and 3 other statins. It's likely that there's not a reason that medically that the person can't take a different statin. The pharmacists are great about understanding that because they really understand the pharmacodynamics of how all that works, and they are very happy and very efficient at working with the healthcare provider's office to make sure it's okay to substitute or switch. And a lot of that goes on behind the scenes between the pharmacies and the providers, and our clients don't know that. When we get calls, it's because our clients know it and there's a glitch, and that's when we can intercede. If the physician or the prescription writer, I should say, believes that none of the drugs on the person's drug plan list are going to work for that person, for their condition, they can ask for an exception to the formulary. The drugs, the categories that are protected, that all the Part D plans are required to cover a huge range of medications for are listed here. Cancer, HIV/AIDS, antidepressants, antipsychotics, anticonvulsives, and immunosuppressants. All commercially available vaccines, and most compounded medications, but that's a little bit tricky. In some ways, many compounded medications are not covered, but if the entities within a compounded medication are covered, then the compounded medication can be covered. In other words, if you take lisinopril slash, let me think of a better example. If you take, well, I can't think of a good example at the moment, but let's say you take a medication that's oxycodone with acetaminophen. Oxycodone is approved, acetaminophen is approved, then the medication that combines the two would be approved. The kind of compounded medications that are not approved are things typically like creams or sprays, where a compounding pharmacy makes it up themselves as they go, and then there's no way for FDA to have any control over that, because how a person is going to respond to that is going to be dependent upon their weight and a whole bunch of other things. So some medications are excluded by law. That includes things like medications for weight gain, weight loss, growing hair on your head, which is kind of a cosmetic thing, prescriptions, minerals and vitamins. So yesterday I was on the phone with somebody who takes magnesium tablets, and that's considered over-the-counter, not covered by Medicare. Generally speaking, but not always, there's a tier structure from tier 1 through 4, but I have seen tier 5. Typically, again, but not always, the lowest cost medications that are generic are tier 1, and then the preferred, either preferred generics or preferred brand names are tier 2. Non-preferred are tier 3, and specialty, injectables, unique, very high cost are tier 4, or could be tier 5, or considered a specialty tier. That has direct impact on the cost. Plans can only change categories and the classes of the categories and the tiering once a year. They cannot move that around in mid-year. If they do make a change to the formulary, they have to get approval by CMS, and they have to notify clients that are impacted by that 60 days before the change, and they cannot force you to take that different drug. You can ask for an exception. Now, if an FDA removes something for safety reasons, it is going to disappear off the formulary very quickly because it's a safety issue. Now, here's what I call the 3 horrible hoops. and I guess I'll need to write a song someday about the 3 horrible hoops. Prior authorization, step therapy, and quantity limits. You know, if all things are equal for a person selecting a plan, and you're helping a person select a plan, if all things are equal, meaning the cost is the same and the pharmacy network is the same and the person doesn't really care what the name of the plan is, if you can avoid enrolling somebody in a plan that has either prior authorization, step therapy, or quantity limits, please do, because otherwise you're requiring them to go through one of these horrible hoops, which is frustrating to the client and causes typically more work for the pharmacy. Step therapy is when is a coverage rule where the person is required to try a less expensive drug on the plans on the formulary that's been proven effective for most people with that condition before they can move up to a more expensive drug. If the person has already gone through that and, for instance, had an allergic reaction or had a horrible adverse reaction to a particular medication, they typically do not have to go through that terrible process again to prove to the plan that they qualify for the medication. But they have to show documentation. And so they have to work with their healthcare provider to get that information to the plan saying, hey, I've tried this, this, and this, and none of them work. They all make me have horrible hives and sweat like a pig. And the documentation should be enough to kick open the person's ability to get the medication that the provider prescribed in the first place. Oh, I'm sorry. Quantity limits is typically for safety purposes, like some medications that are controlled or that are dangerous you can't get a 6-month supply of because you could kill yourself if you overuse them. So some medications you can only pick up 30 tablets a month, that sort of thing. I'm going to skip that. And in the future, so there's a new requirement that all prescribers be enrolled in Medicare or have validly opted out. And that new requirement is going to go into effect in 2019. It's been delayed a number of times. So in 2019, patients, pharmacies, healthcare providers are all going to be talking about this new requirement. It's really not a big deal requirement. It's not requiring all providers and all dentists to enroll in Medicare. It's just requiring them to either enroll or opt out, and for that to be on file with the Medicare administrative contractor. So it's not the federal government saying you have to participate with Medicare. It's saying if you don't, you don't, but you're not going to be able to prescribe anymore and have your clients' medications covered if you don't. We'll worry about that at the end of 2018. If the person's prescription changes, then of course they have to work with if their provider changes their prescription, they're going to have to work with their plan to get the new prescription. A great thing that physicians and providers love is if the client gives their provider the formulary. And I have had many a client, I've helped people print out their formularies and bring it to their primary care physician, who can then look up whether they should bother prescribing a medication or not. Now, for all the physician practices and hospitals that are using electronic e-prescribing, they can automatically see the formulary and whether the medication that they're about to write a script for is on formulary and avoid a lot of hassle, which is one of the many benefits of utilizing a practice that e-prescribes and has an electronic health record. The pharmacies are really good about reaching out to clients who typically have complex conditions and offering them medication therapy management, which they can then bill for. And that will help patients taking a lot of medications understand that there can be interactions. There may be a conversation about whether they need to have a MediSet service. and so forth. The requirement is that the medications have a combined cost of almost $4,000 a year. The person has several chronic health conditions, and that either the pharmacy staff offer it or they ask for this medication therapy management, MTM. Okay, this is a lot of information. We're moving over to slide number 43 to lesson 4, which is about eligibility and enrollment. The who, what, when, where, and why of Part D eligibility and enrollment, which sometimes the more you know, the more confusing it gets, and at other times, all of a sudden, it will dawn on you that it's pretty simple. Kind of just depends where you are and how much you actually counsel and talk to people. In order to sign up for Medicare Part D, you have to have either Part A or Part B or both. You do not have to have both, but you have to have one or the other, and most people have both. You must have Medicare Part A and Part B to join a Medicare Advantage plan. Medicare Advantage plans are also known as replacement plans. So, of course, if you're replacing original Medicare Part A and Part B, you have to have Part A and Part B because you're going to be replacing it with a Medicare Advantage plan. You have to live in the plan service area, which is typically the state, a particular state, although for Medicare Advantage plans, it's county. You cannot be incarcerated. If you're incarcerated, you're under the jurisdiction medically of the Department of Corrections under the state. So you cannot have a Part D plan and also be incarcerated. You have to be lawfully present in the United States. You cannot live outside of the United States, which is a bit tricky because there are plenty of people that live outside the United States for 6 months of the year in the Philippines or in Thailand or in Mexico. But when they're in the States, they get their medications. And in most cases, you have to join the plan, either the Part D plan or the Part C Medicare Advantage plan. Creditable prescription drug coverage is, if you have creditable prescription drug coverage, it's one way to avoid, I guess, or delay signing up for Medicare Part D. And creditable prescription drug coverage can come from an active employment, a former employer, a union, TRICARE, the VA, the Federal Employee Health Benefits Program, or the Indian Health Service. All of those are considered creditable prescription drug coverage. The definition of creditable is generally coverage that's as good, if not better, than Medicare. So a broad formulary, access to a lot of different medications without enormous deductibles and copays. Every plan that is providing creditable coverage for a person is required to send out a letter, or it could be emailed in a newsletter. So it is not true that you will necessarily meet every client that says, oh, I never got a letter. That could be true. If they retired, for instance, I retired, and I checked off a box saying, I don't want all this stuff sent to me in the U.S. mail, just email me the newsletter. It's up to me now to read the newsletter for my creditable prescription drug certification. If a person delays enrollment into Part D, and they can avoid the late enrollment penalty if they can prove that they had creditable prescription drug coverage. I'm going to go kind of fast over in these enrollment periods because SHIBA folks have had this tons of times, and so there's the 7 months golden opportunity to enroll in Part D 3 months prior to the month of the 65th birthday and 3 months after turning 65. I call that the golden window of opportunity. We're coming up on the annual open enrollment period, October 15th to December 7th. During the Medicare Advantage, if a person's in the Medicare Advantage plan, they have, I think I'm going to call it, I think somebody taught me, the disenchantment period. They can leave and switch to original Medicare between January 1 and February 14th. Just think Valentine's Day. And they only have until February 14th, likewise, to join a Medicare prescription drug plan. They do not have the typical 63-day special enrollment period, which would take them through March and April. This is new to me. I learned this last night. If a person doesn't have Part A coverage and they enroll in Part B during their general enrollment period, which I call the doghouse period, they can then sign up for a Part D plan from April 1 to June 30th with a start date of July 1 of their Part D. But they can only do that between April 1 and June 30th. So that's a bit crazy making because they've already made a mistake probably, and they sign up for the general enrollment period for Part B, and then only after that enrollment period is over can they sign up for Part D. So those folks are going to need a lot of hand-holding, in my opinion, to get it right. There are some reasons that you can get out of, you get a special enrollment period if you move, if you lose other coverage, if you were not ever properly told that you didn't have creditable coverage, or you had creditable coverage but then it became not creditable coverage and you can prove it. If you move in or out of a long-term care facility, or if you have extra help, if you belong to it. I don't think we have an SPAP in Washington, but many states do. Or there's the opportunity to join a 5-star rating plan, and we don't know if we're going to have any of those in Washington next year. Also, if there is a really poor performing plan, that can kick open a one-time option to switch to a different drug plan. That's kind of a nightmare, and we hope it won't happen, because clients will freak out when they get a letter saying that your Part D plan is a low-performing plan. It does not mean it was low-performing for them, and it does not mean that there is another plan available that will cover all their medications. I'm telling you this from heartache experience. So a lot of times people are better off to stay in the low-performing plan than to spend 3 days trying to find a plan to switch into. There's a late enrollment penalty. We kind of know how to calculate that. It's going to be 35 cents a month in 2018 for every month that a person chose to not have Part D coverage. So, that number switches. It just went down a little bit. But we can typically guesstimate, well, if you haven't had, if you didn't have, I'm going to skip that. We know how to do that. And I typed out an example, and I used my calculator to make sure it was right. We can assist people in guesstimating how much their late enrollment penalty is really the point. Let's move over to extra help, page 54. And I'm going to kind of glide through some of that. Extra help means prescription drug coverage is going to cost less. It's a Social Security program. The limited income subsidy, or also known as extra help, is a Social Security program. It coordinates through data feeds weekly with DSHS or the HCA in Washington, based on income and resources. When a person has extra help, they have a continuous special enrollment period. So if they want to change every month to a different plan, they can. It would be a nightmare, but they can. and we're pretty familiar with the income and resources. The 2018 numbers, as far as I know, don't come out until March or April, so we're still working off all of the SHIBA QRCs and guides on my SHIBA that are available. They're still accurate until we update you otherwise. People on SSI, supplemental security income, or full Medicaid coverage automatically qualify for extra help. They do not need to submit an application. They automatically qualify. There's a whole bunch of different ways, and as you know, different colorful letters on how people get automatically enrolled and what facilitated enrollment is. It's pretty deep, and there's lots of different colorful letters, and you're all going to be going over that. If you work for a pharmacy and you want a copy of the colorful letter chart, please email me or call me. I will be more than happy to sing you my colorful letter song and send you that grid. Because clients may come into the pharmacy waving a purple letter and not knowing if the purple letter is good or bad news. So that could help you in the pharmacy really know that there's a chart that is a cheat sheet for you. There's different copay levels. We have this also in a SHIBA document. And yeah, for people that are in the COPES program, which is home and community-based services, waiver, or institutionalized skilled nursing level of care, they don't pay any copayment. L-I-N-E-T, LINET. Some people call it LINET, some people call it LINET, some people call it the LI-NET. It stands for Limited Income Newly Eligible Transition Program. This is for people who are eligible for extra help or Medicaid and have Medicare, but have not yet selected or been auto-enrolled or facilitatedly enrolled into a Part D plan. It's a stopgap prescription drug coverage plan with a wide open formulary. The client, the SHIBA advisor, or the pharmacy has to get evidence, has to know that the person is eligible for both extra help and Medicare. And LINET typically gets that data feed at midnight every night and has it loaded by 8 o'clock in the morning local time. But sometimes a person, just went to their CSO and found out that they were approved for Medicaid and has a letter in their hot little hands and it's not yet in the system. In that case, we can get best available evidence to LINET, and that day the person can get their pain medication or their diabetes medication or, God forbid, their breathing medication. LINET is a wonderful program, but it's complicated. We have a brochure we'd love to get you, if you haven't seen it, on how it works with the 800 numbers, and it gives you the sort of dummy BINs, PCNs, and group numbers and ID numbers to help pharmacies walk through it and be able to enter the data they need into the computer and then dispense the medication that the really desperate, confused client needs. Okay, this is more about the colorful notices. Some people may lose their deemed status. They'll get a gray letter. In my song, it's gray, gray. It's not a good day. It's never good when your LIS goes away. So a gray notice is bad news. There are changes. There are lots of quirky things that happen with extra help. We are the experts. If we can't figure it out, we know who to go to figure it out. And we can always call 1-800-MEDICARE through our SHIP unique IDs and get help with that. Comparing and choosing plans. What I like to say to people is I will be glad to help you select the best Part D plan available for you. And then what is best? Best is the plan that covers your medications, the plan that works with your pharmacy, and that's in network with your favorite pharmacy or a mail order service, and the plan that has the pricing structure that you can live with. If you cannot live with a $400 deductible, but you can live with a higher premium, then maybe you want the plan that's got the higher premium. So, you know, there's these different factors that they have to juggle. Certainly if a person has other coverage, they want to consider delaying signing up for Part D coverage. So we help people prepare by going to the pharmacy, preferably ahead of their appointment, because they can go to the pharmacy and the pharmacist will be happy to print out a list of their medications and highlight the ones that are really the most important, tricky, expensive ones that they want to make sure their Part D plan is going to cover, and some of the less expensive generics that have 15 different replacements that could easily be switched. So that if a person takes 3 expensive brand name drugs and 6 generics, we want to try to help them get on a plan that's going to cover the expensive brand name drugs. Because if they take lisinopril, they could replace it with hydrochlorothiazide or any one of another 10 blood pressure medications. But if you need the brand name Novolog insulin to live, there's not going to be a good substitute for that. So encourage people to go to the pharmacy before they come for their plan. Not afterwards, because afterwards then they're going to have to come back to you and you're going to have to redo the plan finder input. Have people come with their red, white, and blue Medicare card. You go onto Plan Finder, and we're not really going to get into the details. When people do sign up for a new plan, they're going to get an initial enrollment package sometime in December. It's going to give them all kinds of information, including the card or information about how to go on the website and print the card, which, you know, frankly, my 94-year-old mother is not up to doing anymore. It's going to have the abbreviated formulary and a whole bunch of other paperwork. Tell people, keep everything they ever send you. Do not throw it away. It's important. It's gobbledygook, but it's important, and you may need it someday, or I may be looking through it someday to assist you. We know about the annual notice of change. People have already gotten that, and they're getting it in their mail now. People may or may not open it, may or may not read it, may or may not understand it, but legally they have been notified. Real quick, there's an appeal process. If a plan denies a medication, they can appeal that. A standard appeal is 72 hours. An expedited appeal is done within 24 hours if life or health is jeopardized. I would say any kind of breathing medication, any kind of insulin, pain medication as well, because some people will consider taking their pain medication or ending their life, because that's the only way they can end their pain. There's an exception to the formulary. All the plans will be happy to assist people with that paperwork. There's 5 levels of appeal. We're not going to go into that right now, and I'm done. There's only 6 minutes or so. Key points to remember. I hope you all learned something, at least one thing from this hour. This is my contact information, and then possibly with Terry's help, I'm going to you could raise your hand on your dashboard. If you raise your hand with a question, I will try to unmute you and let you ask your question. So feel free to do that. And I'm going to take us off